A very good morning to everyone. I'm Dr. ASHISH AHUJA. I'm a vitreoretina surgeon, and I thank Dr. Nikhil for including me as a part of this IC. So, main focus of my talk would be on the application of OCT angiography, a newer tool in the diagnosis of and management of retinal diseases. So, OCTA visualizes the retinal vasculature using motion contrast and for detailed analysis of the blood vessel structures in the superficial capillary layer, deep capillary plexus, and the choriocapillary layer in the retina. But as for other imaging modalities, OCT angiography is also prone to develop a significant amount of artifacts which are lesser now in the newer softwares and the higher versions of the machines available. So there could be cases where we get white line displacement because of patient blinking, or a stretch artifact which is happening because of the software which is trying to remove the noise and to process the image. The structures in the superficial layers of the retina may project shadows below it. So this is a report of a patient. Even the blink of an eye or small saccadic movements can induce artifacts in the images, which we should be aware of before interpreting the angiography reports. So this tool is very useful in analyzing the foveal avascular zone. So it has importance in picking up cases which are having macular ischemia, patients with a relatively normal looking fundus but vision not improving, or if a patient has macular edema post 5-6 injections, edema is not clearing, vision would usually be less than 6/60, so we have to suspect macular ischemia in such cases. And usually diabetics who have nephropathy, injecting a fluorescent dye might be contraindicated in certain cases. So OCT angiography is a very useful tool where we can pick up the widening of the foveal avascular zone and irregularity in the FAZ. So coming to some cases, you can see in this image, this is of an 85-year-old patient. On the fundus color photo, you can see that there is no clinically visible retinal hemorrhage, but just a grayish reflex seen on the fundus photo. The OCT is showing an increase in the central macular thickness with intraretinal fluid. So the OCT angiography done through the macular area is showing the presence of a CNVM complex. So these patients will require anti-VEGF injections. And besides doing the OCT B scan, regular fundus, along with the fundus imaging, we can see that the neovascular complex is reducing in size over the subsequent injections, and this is useful in treatment planning. Coming to another case, this patient was having a CNVM in a case of pathological myopia. Because of the very thinned out RP layer, such patients are prone to develop a CNVM. This would be at a younger age as well, and this might be preceded with an exertion episode of coughing, sneezing, an injury to the eye, or lifting something heavy. The OCTA will help in revealing the C-fan shaped or various patterns of the neovascularization, and this will help in treatment planning. Sometimes even the OCT may not be able to pick up, or in cases when we have a suspicion. So this is a very useful tool. Again, OCTA can be useful in various vascular diseases. In patients with branch retinal artery occlusion, there is loss of the vasculature in the superficial capillary plexus, but this was a study in which they had shown that the deep capillary plexus was being restored sooner. So we can see the speed at which the recirculation is happening, and it will help to prognosticate certain diseases as well. In cases with again ischemic branch retinal vein occlusions, we will be able to pick up areas where there is capillary depletion and capillary dropout. Coming to cases of proliferative diabetic retinopathy, India being an endemic for diabetics and the global capital, so this is a very useful tool to pick up suspicious neovascularization, or many a times it will not be picked up on a routine slit lamp with 90D or fundus evaluation. So Octa will help in picking up uh, small neovascular fronts, and this will help in treatment planning and following up of patients. The newer OCT angiography devices can provide a very wide field of view, almost 12 by 12 mm or even larger. So again, showing another case of PDR, the fluorescent angiography is showing increase in the fluorescence near the vascular arcade, and the OCT angio is picking up and delineating the structures very well. So even though we can't see the flow pattern or the increase in leakage of the dye which is picked up in an FFA, but the structure is delineated very well. Again, in a case of CSCR, these are usually younger patients between 30 to 50 years of age, type A personality, or who have a risk of smoking, presenting with blurred vision. OCT showing there is presence of subretinal fluid. Again, this CSCR is known to be a part of a spectrum now called pachychoroid disease, and this can progress over time for patients to develop a pachychoroid neovasculopathy or polypoidal choroidal vasculopathy. So such cases will also have useful implication of being Octa being performed in such cases in patients especially who have recurrent development of subretinal fluid in spite of doing an FFA, focal laser, controlling the risk factors. So we should suspect neovascularization in certain cases. This image is showing the effect of performing a focal laser after doing an FFA in a patient of CSR. So you can see that there is a loss of the choriocapillaries in the area where the focal laser has been done. Again, in macular telangiectasia, we can pick up the abnormal telangiectatic blood vessels in the area close to the foveal avascular zone, very typical of MACTEL. And these patients are also prone to develop a CNVM more at the later stage of the disease. So this can help in picking up the disease early, and the patients will have a good vision usually in such cases because it is parafoveal. Patients would maintain a 6/9, 6/12 vision, and if we can pick up the CNVM complexes and treat them early, we can help in preserving the vision in a lot of cases. So this is a useful tool, but the drawback again being the cost of the device, but hopefully in the years to come, the cost is going to decrease. There is a definite need for Octa in our clinical practice. It's a new tool with a great potential, and compared to FFA and ICG, which are the current angiographic gold standards, Octa has an advantage of being non-invasive. It acquires volumetric scans that can be segmented to specific depths. We can analyze the retina and the vasculature at a particular level. The Heidelberg OCT gives us even the intermediate capillary plexus, which is connecting the superficial deep. We can analyze the choriocapillary layer. So we can see NFAS imaging. We can analyze a particular layer of the retina and study the vasculature there. This is giving more insights into the disease pathogenesis as well. The images can be obtained within few seconds. It provides the accurate size and the localization of the vasculature. Another disadvantage being, the inability to view the leakage which is happening from the vasculature, and there's increased potential for artifacts, which is reducing now as the softwares are being upgraded. This tool has been there now for almost 6 to 7 years, and the amount of artifacts are reducing now with the increase in the speed of the A scans and refinement in the software. Thank you.
I think excellent presentation and very detailed. So just one question I had for you. So we've seen that in the past decade, the role of angiography has depleted. What do you feel it would be for the next decade? As you mentioned that it does not look very economically viable as of now. So if someone's investing in this machine now at the moment, do you foresee that in the next decade the role of that angiography is going to go further down?
See, role of angiography has reduced definitely over the past decade, and but this is not going to replace the traditional FFA. Again, analyzing the choroidal vasculature is not that good at the moment, except for the choriocapillary layer. So certain diseases like PCV, we need ICG. We need to see the flow through the vessels, how the leakage is happening. But there is a lot of development happening in Doppler based OCT, where they are analyzing the flow as well. That technology should also come within the next 5 to 10 years. But FFA and ICG for now are here to stay.
Thank you.